After the talk on the gender differences, I'm going to take a step back to gestational diabetes and an opportunity of prevention, mind you, not type 2 diabetes, but CVD. So with that, so the agenda of my talk will be just to give it a platform. What are the different forms of gestational diabetes? What are the risks in gestational diabetes? What are the common risk factors and pathogenesis in GDM and CVD? And then looking at what happens to CVD in mothers who had gestational diabetes and what happens to children of mothers with gestational diabetes as far as the cardiovascular risk is concerned. So we do know that there are different forms of gestational diabetes. It could be autoimmune, that is type 1. It could be type 2, which is a background of insulin resistance. It can also occur in genetic mutations or pancreatic or endocrine function problems like pancreatitis. However, 80% of gestational diabetes occurs in a background of type 2, where we have beta cell dysfunction and chronic insulin resistance. This also has reduction in glucose utilization and increased production, not only of glucose, of also free fatty acids. And we do know free fatty acids are a risk for CVD. The beta cells deteriorate due to this excessive insulin production or because of the resistance. And because of this and the energy consumption, the beta cells exhaust over time, and then frankly, diabetes may happen. So this is the risk of gestational diabetes. People with gestational diabetes have a threefold increased risk of type 2 diabetes. The yearly conversion to type 2 diabetes is about 2 to 3%. And they also have a risk of metabolic syndrome, which is not just diabetes, but all the other factors like blood pressure, lipids, as well as cardiovascular disease. Now, once a lady has gestational diabetes, the vasculature of these women is permanently altered, predisposing them to cardiovascular disease. And this is why we say that they have an increased risk of CVD, but we look at some data. Now, this was a follow-up study of gestational diabetes. This was a very elegant study done in Denmark. One study was done way back in 1978 and followed until 1985, where around about 241 women who were treated with diet alone were followed up and seen what happens. What happened over the 6 years period? 18% became diabetic and 17% had pre-diabetes. So that was the first 6 years. They followed up for another 13 years, which was a median of 19 years. And what they found is 37% of these 151 which were left had diabetes and 29% had pre-diabetes. Only 1/3 was normal. So the same group did another study, same in Denmark, between 87 and 96. And what did they find for a median of 7 years? And but there, 41% already had diabetes and 26% had pre-diabetes. That means there was a threefold increase between earlier study and a later study. And the only difference between the two groups was weight. Like Chitra was saying, that obesity is a huge confounder that we need to address so that we can prevent this progression. Now, what are the common risk factors of gestational diabetes and CVD? We all know overweight, obesity, gestational weight gain, what they gain during the period of gestation, westernized diet, ethnicity, certain genetic polymorphisms, advanced maternal age, the intrauterine environment, the family history, and associated disorders like the polycystic ovarian syndrome, which we are increasingly seeing in our endocrine practice. Now, what is the major problem of gestational diabetes and insulin resistance? As you can see in the right side upper hand corner, the insulin, this is normal, that is the first stage where they don't have, that's before pregnancy. During pregnancy, the insulin resistance increases, the IRS1 receptor becomes, there is a lot of insulin resistance over there, that's peripheral insulin resistance. And after delivery, the hyperglycemia may come down, but the insulin resistance and the certain damage remains. Now, apart from that, and we all know all the other factors which causes increase in blood glucose as well as insulin resistance, but added to that, We also have the placenta causing insulin resistance by increasing placental leptin, pro-inflammatory cytokines, and the placental transport of free fatty acids, and the fetal growth itself may cause insulin resistance and hyperglycemia. So there is an abnormal metabolic risk profile in gestational diabetes. This could be due to epigenetic factors of maternal hyperglycemia at the skeletal muscle and the subcutaneous adipose tissue. And these have been confirmed or got from epigenetic analysis. Now, what happens? Let's say the patient was having diabetes or had diabetes but didn't know about it. And here, the parameters that are important are, of course, ethnicity, physical inactivity, obesity, dietary composition, and polycystic ovarian syndrome. And what they do, they cause the insulin resistance, while which all the inflammatory factors like the tumor necrosis alpha increases, the placental lactogen, growth hormone, estrogen, progesterone, cortisol, all of this increases, causing increased glucose levels. And there in the mother, they have persistent hyperglycemia, we do know, but they also increase triglyceride and increased amino acid turnover, which leads to the substrates for the fetal growth and the enhanced fetal growth and the hydrolysis to free fatty acids in the placenta. So we look at what all this does in the child and in the mother. So there have been certain pathogenesis for CVD and gestational diabetes. One of it is diet. So overweight and obesity overwhelm the beta cell insulin production and the signaling pathways. And they have seen that diets rich in saturated fats, especially in gestational diabetes, cause more of the insulin, interfere more with the insulin signaling. And increased fiber is important, and it improves the insulin sensitivity. Processed meat can be responsible also. It increases nitrates, which increases beta cell toxicity and amino acid production, which is a substrate for HGP and hepatic lipotoxicity. It also induces inflammation and endothelial dysfunction. Both are the pathogenic factors in both GDM and CVD. And of course, if N3 polyunsaturated fatty acids have anti-inflammatory properties. Now, birth weight. The birth weight of the mother also has importance, because they have found that if the birth weight is less, that is also a problem. If it is more, that is also a problem. So if the birth weight is low, the fetus will compensate for this undernutrition by altering the expression of genes in fat storage and utilization and the appetite regulation. And this is associated with decreased number of beta cell in the pancreas. These alterations persist after birth, and this is called developmental programming. And this contributes to obesity, metabolic disease, and CVD, or what we generally call endomorphic fat obesity. This overnutrition in the womb, if there's more nutrition, can also result, like I said, the fetal overgrowth. The hyperglycemia causes beta cell fatigue even before birth, and after birth, it predisposes them to hyperglycemia, especially in stages of metabolic stress, even the next pregnancy, if that is a girl. So that is why it's a vicious cycle. So the first of its study was done way back in 2005, which was published in JCEM, looking at what are the common factors between CVD and the GDM. And what they found was all the inflammatory markers were increased, like you see, whether you see CRP, PAI, interleukin 6, or adiponectin was, of course, the adiponectin is protective. If you see that in gestational diabetes, it was quite high as that in people with subclinical vascular dysfunction. So this said that in people with GDM, they have subclinical inflammation by inflammatory markers. Now, this was another early study, that is in 2016, where the interest started about cardiovascular events in women. And again, a large number of people were studied. And in this, about 62,000 women had gestational diabetes. And what did they find? After adjusting for age, diabetes, obesity, and hypertension, they found that they had a higher risk of CVD with an odds ratio of about 1.25, angina pectoris odds ratio 1.68. That means they are double the risk of angina and a myocardial infarction, and hypertension was almost 3 times. But this study did not show any association with increased risk of stroke. Another study was done. This is the same study which looks at the significance, and you can see here, and this is a very small slide. I mean, it's a very busy slide, and I will just tell you, but what was significant in all of them was hypertension, angina, and myocardial infarction, both acute and repeated myocardial infarction through time when they studied over a period of 7 years. Apart from that, the cardiovascular risk profiles itself, if you look at the cardiac output, the stroke volume definitely was significantly reduced in patients with GDM compared to the normal people. So it was just not the ischemic heart disease, but even outflow or the cardiac function was also affected in this manner. So now they concluded for the first time that GDM is an independent risk factor for CVD in the 7 years following delivery, and suggested that effective management should be done. So that was the first study. This was another study somewhere around around 2006, which came out, which said those women who had GDM, but also had a family history of type 2 diabetes, were more highly prone for cardiovascular disease. So here again, blood pressure was significant. And if you see the fasting plasma glucose and the metabolic syndrome was significant. And again, coronary artery disease showed a trend and CVD was significant, but stroke did not show much of a difference. So both the studies go on to say that gestational diabetes is a risk. So again, this is a study which showed that in patients without GDM and with GDM, even if you adjust for age, you can see whether it's total CVD, myocardial infarction was trending, so coronary revascularization or heart failure, or even cerebrovascular stroke was significantly more in persons with GDM compared to people who did not have gestational diabetes. This was another study among elderly Chinese, which is called the reaction study, which again showed that, of course, gestational hyperglycemia, you will get diabetes, but the odds ratio of increased risk of CVD was about 2.88. This is a very recent study, which was published in August 2021. And even hypertension risk was as high as 3.98. That is almost 4 times more than diabetic pregnancies. So this was another study which actually when Dr. Chitra showed, but she showed an older study which looked at, I don't think it looked at gestational diabetes, which looked at diabetes itself in women, but this was one which looked at the gestational diabetes and what happened when they followed up and looking at the coronary artery calcium during midlife. And what they found was the coronary artery score was present in 25% of women with gestational diabetes compared to only 15% with no gestational diabetes. And the hazards ratio was about 1.54 for those who had no gestational diabetes but became pre-diabetic later, and 2.17 if they had GDM and went on to have incident diabetes later. So yes, we are worried about it and we are looking at prevention. So there have been studies which have looked at preventing cardiovascular disease in gestational diabetic women in the later stages, but unfortunately we don't have too good data. We have Upbeat study which showed that did not have any use. Then there was the DALI study which looked at vitamin D and lifestyle. There was a 33% reduction in CVD in GDM, but it was not significant. This was a radial study by the Finnish group, which did show that there was an improvement by 39%, reduced incidence of diabetes as well as CVD, but it should be replicated because there's a lot of critical analysis on this saying the population was not well represented. So we need more data. Now let's look at what happens to the fetus. Now, in the long term, babies that are born of gestational mothers are increased of risk of obesity. We know that type 2 diabetes and also CVD. So it's not just an opportunity to prevent CVD in the mother, it's also an opportunity to prevent CVD in the infant of the mother who has gestation diabetes. So the children born to mothers have double the risk of childhood obesity compared to their non-diabetic counterparts who were delivered from non-diabetic mothers even after adjusting for confounders. Females are therefore more likely to have a GDM as a vicious cycle from the child again becoming having gestational diabetes in her pregnancy. So this was another study which was published in BMJ in 2019, looking at offspring. This was a very good study, which looked at 40 years of follow-up. They looked at about 1,100 offsprings of mother with diabetes, and also about 91,000 offsprings of mothers who did not have diabetes, and seen what happens to the cardiovascular risk. And what they found was there was a 29% overall increased risk of people, of children, of offsprings of mothers with diabetes to get CVD compared to the other counterpart. And if there was pre-diabetes, there was a risk was 34%, and gestational diabetes was 19% for CVD, not particularly heart failure, hypertensive disease, deep vein thrombosis, and pulmonary embolism. This increased rate was pronounced if the mother had diabetic complications, it was even more. And if they had comorbid CVD itself, it was about 73 times more than that of the person, 73% more than that of the other control group who did not have diabetes. So this was something which was very, very shocking. And this is the same study. And you can see as time goes over 40 years, how the risk for the exposed has exponentially gone up compared to the unexposed. So what are the clinical perspectives of all this? So the clinical perspective is women with no history of gestational diabetes, progression to impaired glucose tolerance or over diabetes within 15 years was associated with a graded increase in relative risk, just like everybody else, of coronary artery calcification. But women with history of gestational diabetes, the relative risk of coronary artery calcification midline was twofold higher for those with normoglycemia, impaired glucose tolerance, or overt diabetes within 15 years. Here you see, even if they remained normoglycemic later, or they had impaired glucose or became diabetic, the risk was almost the same, twofold increase just with the history of gestational diabetes, irrespective of what happened in the later stages. The clinical implication of this is, even if we keep normoglycemia in women with previous gestational diabetes, can we reduce atherosclerotic cardiovascular disease? This seems to, at present, suggest no, it may not completely reverse. This history of gestational diabetes may entail underlying vascular changes which adversely affect the cardiovascular disease and the pathways of insulin resistance, which are common and promote atherosclerotic plaques, independent of dysglycemia later. And this is the mounting evidence which says that we have to screen women for gestational diabetes, not only screen, stratify them, risk stratify them for better treatment for early atherosclerotic cardiovascular disease and prevention. So to conclude, gestational diabetes has a marked impact on the future health of both the mother and the offspring. The prevalence of gestational diabetes is increasing in most populations and definitely in the Asian Indian community. And it's likely that it's going to play a huge role, not only in people becoming more diabetic, which we can ill afford, but also getting coronary vascular disease or cardiovascular disease. So we need to have effective interventional strategies for preventing and reducing these metabolic derangements in the mother prior to pregnancy, during that, and even after delivery. And it should be implemented by all of us in a war-footing manner so that we can prevent this condition of cardiovascular disease, which is again going so high in our country, so that we can achieve a better care for our women. Thank you very much for a patient hearing.